Let me see if I can highlight some of the complexities in the healthcare system, and the goals of this video are going to be, well, 4 of them. Goal number 1 is I'm going to try to highlight, I call it the 5 decision makers of healthcare, and you're on your screen here. This is Flowers R Us. It's a local business. Then of course here you're in the middle, and then over here is managed care, and then here's the doctor. She's got a little stethoscope around her neck, and then here's the hospital, and then here's the U.S. government. So the 1, 2, 3, 4, 5 decision makers in healthcare. The second thing I'm going to show you is, as we're looking at or highlighting the relationship between the 5, always think of 3 things: cost, how much it costs to deliver healthcare; the accessibility; and finally, the quality of healthcare. Those are the 3 things that you should always focus on when a healthcare plan has been changed, or if the government tries to implement a new change in healthcare. Cost, access, and quality. And I like to put quality in the middle, so I think it's the most important. Number 3, as I'm showing you some of this, think about one of the pillars, the pillars unknown, cash flow. Think about how cash flow, if you are working down here for the provider. And finally, number 4, look how easy it is, as I do this, to shift the cost back to the person here in the middle. So the 5 decision makers: quality, accessibility, affordability, the unknown cash flow to the providers, and finally the cost shifting behavior. Those are the 4 things. So let's go ahead and get started. I'm going to start and highlight each 5 of these. Let's start up here at this one here, the employer-based healthcare. This is something that came out, and I'll just write it here, in the 40s. Some people think 43 was a big year for this. A couple things happened in 1943. Well, the first thing that happened was FDR implemented a wage freeze, but also the Revenue Act of 1943. So some people think the Revenue Act of 1943 is more important here. But in 1943, with the Wage Freeze Act and the Revenue Act, which made tax purposes of healthcare pretty cheap, and all this came about from the 20s in Texas, in Baylor, Texas. The Dallas Teachers Hospital got together with the teachers union and said, if you pay 50 cents per month, we'll provide health care coverage to you. And that was actually the precursor of Blue Cross. And then of course when the Revenue Freeze Act happened and we made it really beneficial for tax purposes, these businesses had to attract employees, so they just said, well, I can't do it with pay, I'll do it with a benefit known as health care coverage. So you get this job here and you get this wonderful benefit of healthcare coverage. Now, some people like it, some people don't. Some people think it locks this person into a job, which it can do that. But that's the benefit that they provide. And the neat thing about this is that because of some other tax laws in the 43 and actually 54, it made it easy for this employer to also help you out and pay for some of it. Now, once you hit this job, you have this benefit. You pay yourself your premium as well, which I refer to as a sunk cost. So now you have a healthcare coverage through this employer, and the employer's helping you pay a portion of it. It may be 50%, maybe more, maybe less, but they are helping you out and they're offering this benefit. Now, come down here to the government. The government didn't really, other than the tax laws, didn't really get big until 1965. In 1965, they signed to the act called Medicare, which they got the name from Canada. That's Canada's system, and Medicaid. And the difference is this is more of a federal run. This is a state run. I'll keep this out of here for right now because it's usually paid for, usually 50-50, sometimes more, sometimes less. The federal government pays for 50%, and then, of course, the state will pay the other 50%. And I'm going to leave the exchange out, but it could put the exchange in here, but I'm going to keep it simple and leave the exchange out. And here's Medicare. Well, Medicare has 4 parts. It has Part A, Part B, Part C, and Part D. Part A mostly is the skilled nursing, hospice, and hospitals. Part B would be your medical necessity type things, preventative care. And then the patients have to check on this because if they have a Medicare C plan, which is like an Advantage plan, it changes some of the things in A and B. And then finally, D is the drug plan, drugs and things of that nature. 65 is a pretty big year, and also another big year for the government is 82 and 82. These are the 2 big years. And what happened in 65 when the government passed Medicare, managed care, really blossomed. Wasn't really big, even though you see these in the 40s and 50s, but it really took off when the government started Medicare here. And what managed care does is it kind of follows in suit with Medicare. So 65 started Medicare, and a lot of the terms, all the terms we have from the government are adopted by Medicare, whether this is Blue Cross, Blue Shield, Humana, Aetna. And then, of course, the big year was 82. 82 changed the way we paid. We used to pay after the fact, that we call it a retrospective system, but now after 1982 they call it a prospective. That means they pay before. So what happens here is if a Medicare patient goes sees a doctor, the payment before 82 was billed maybe like a fee for service, but after 82 it was billed basically per case reimbursement, or maybe per hospital stay. One of the big terms we use is called a DRG, a diagnostic related group. So they pay before. So we did see a little uptick in patients being released early, and they've been studying that a lot, how this affected the prospective system affected it. But of course, it's implemented today. Let's go back up to the managed care and look at the relationship. This is where it gets really fun, right here. And I'm going to just throw a couple of them out. I'm going to show the first one. I'm going to say that this person here gets the benefit. Doctor, they pay, the business pays, and then they pay their premium, and they get an HMO, Health Maintenance Organization. An HMO usually pays maybe something like a capitation. A capitation, you're going to learn later on, very important concept. It's a upfront payment, almost like this DRG. So basically, let's say I get this card in the mail, and this card, if I want to go see this doctor, says I have to see her. She's referred to as my gatekeeper. And my gatekeeper, or they call him the PCP, is the only one I see. My name is on her card. Her name is on my card right here, the little card I have in my hand, my little insurance card. So I go see her, and I pay my copay, which could be we'll say $30 for this particular office visit. I pay that up front. And she may have 5,000 patients that have that card. Therefore, she gets paid maybe $1 per. So every month she gets paid $5,000. And then she gets the $30 from me. So in essence, technically I'm worth $1 per month plus this $30. And this is how capitation works. It puts the ability of saving the money or lowering the cost back on the physician here. Is it possible this physician would withhold services knowing that I'm only worth that amount of money? So if I come back 3, 4, 5 times, even though she gets the $30 each time, I'm burning away this fixed capitation. It is possible. Now the other method, and there's a lot of methods. I'm just going to just highlight the two, and I've got a hospital here. I'm not going to, because there's a relationship here. Generally, doctors might or might not work for a hospital. The other method, and I'm going to put the arrow here, is that maybe I didn't get this card with an HMO and I have a gatekeeper. Maybe I got some type of preferred provider organization. Now, generally with those, it's a contract. So what happens is this managed care contracts for different physicians. So if I got a rash and I want to go see a dermatologist, I can't here. I have to go see her, my primary care physician, which could be a PA, could be a nurse practitioner, it may be a DO or an MD, and then they'll refer me out to a dermatologist. But with a PPO, it gives me more flexibility. So if I have this card, it'll have a list of doctors. I can go see these primary care, or that rash is kind of bothering me. Therefore, I'm going to go see a dermatologist. So I can go see a dermatologist. So it gives a little bit more flexibility. So if you take a look at this whole convoluted system here, you have 5 people or 5 decision makers in healthcare. You've got the government that makes laws and pays, especially if you're over the age of 65. Ironic, it was made in 65. You've got the business involved here, and some people don't like the fact that your business is involved, but they are. And you got managed care that's involved, and you got your doctor, and you got you. And I tend to think that you're the most important person here, but you can see how convoluted this system is and how easy it is for the doctor to just to increase your copay. In addition, with this PPO, there could be some type of deductible. It's kind of like if you have a car accident, you have a $500 deductible, you pay the first $500, and then the rest kicks in with the insurance. So it's real easy for all these contracts and these decision makers to have a lot of ability to shift the costs back to you. Your employer says, I can't afford that, therefore I'm going to pay less. So the next year you sign up for your health care coverage, you get to pay more of this. The doctor can erase copays, and we've seen that for the last couple of years, this cost-shifting behavior, if you will. Now, if you work for the provider, you can also see how difficult it can be to know your cash flows. And well, I hope this helps. And again, lastly, I want to make sure that people understand that this is what it's all about: the cost, the accessibility, and the quality of healthcare. Every time this government entity attempts to make any change, they should take into consideration this first, second, and third. Now, I won't talk about the Affordable Care Act of 2010 with the exchanges, but technically speaking, what the government did was they created a system of the states had to create an exchange or a federal exchange and increase Medicaid. Very interesting. So if you get a chance to read some of that, it is. But I just want to, at this point, highlight some of the healthcare delivery system to give you kind of an idea how it works.